Thank you both for the talk. They were really interesting. And it's a question to both of you, really, I suppose in looking after patients in the hospital environment, is how important is skin and nasal decolonisation when it comes to C. diff and yeast and fungi?
Do you mean decontamination in the environment or decolonization in patients?
I mean decolonisation in patients.
Decolonization.
So cleansing the skin of any spores or any planktonic organisms on the skin or in the nose.
Yeah, there are studies that suggest that the skin of patients with CDI is also heavily colonized with the spores of C. diff. And also that even if you are not colonized in your intestinal tract with C. diff, then you can be colonized with C. diff on your skin. Those studies are there. So I don't know to be sure how important it is to eradicate all those spores from the skin and from the environment. If we do, I mean, that's similar as the decolonization of patients. In the decolonization of patients, we have done a study in which we could not demonstrate an effect of decolonization with the effect on the whole of CDI in the hospital. And also in those studies that isolated patients that were colonized, there's no clear effect on the total incidence of CDI in the hospital, except in outbreaks. So I think in outbreak situations that everything differs. And then you have to move to, okay, what is the role of the environment and what is the role of the skin of patients in the spread of C. diff in the hospital? Because then you have to combat the spread of C. diff and not to treat only patients. So yes, to be sure, I think it's pretty important in outbreaks. And in outbreak situations, you should do all the efforts that you have to get rid of C. diff spores in the environment, and you should do everything to prevent that colonized patients can spread the spores to the environment and to other patients.
Yes, thank you. In the context of fungal disease, colonization of the skin is very common for particularly yeast, and it's quite clear that there are hospital outbreaks in which you can see the clonal expansion of a strain from patient to patient, often via healthcare worker as well. So that is important. And auris, Candida auris, which I mentioned, is a particularly difficult one because we know it hangs around the environment for long periods of time and sits on medical devices or on bed linen, etc., for periods of time. Other fungal infections are commonly the route of infections via the lung. Those are usually infections which are acquired from aerosol, not from necessarily the hospital environment. They come in pre-colonized, although you'll be aware that we try and minimize exposure to spores through in intensive care wards where we don't allow flowers, etc., which can be a potential source of infection. It's clear also that when you look at healthcare settings in the US, for example, intensive care wards, I believe, usually are much more beds in one place, and they tend to suffer more from the spread of Candida auris infections, which have actually been relatively well contained in the UK. I think there's only been one attributable death to Candida auris in the UK, which is dramatically different to many other places. Plenty of colonization events, but actually awareness of that problem and knowing how to rapidly deal with that if there's any prospect of a systemic infection developing.
Well, first of all, thank you very much for your talk, both of you. They were absolutely fascinating. I've got a couple of questions, if I may, for both of you. If I start with Neil first. You mentioned a number of interventions like new antifungals, biologics. I thought at one point there were some probiotic approach for vaginal thrush based on lactobacilli formulation. Do you think that's a potential, or it's definitely no? On the second question is, so far, you mentioned treatment in the lab, antifungal test. Usually they're on, I guess, like planktonic fungus. What about biofilm treatment? Because with vaginal thrush, for example, I believe it's more biofilms, and biofilms, fungal biofilms, especially Candida, are an issues.
Yeah, shared with the bacteriology, biofilms are a major problem, and fungi many species of fungi are adept biofilm formers. And as in bacterial biofilms, there is this capacity to reduce the access to drugs to the cells, and so there's a protective layer for those. So biofilms are really problematic in that setting as well. In terms of thrush, it turns out that the main pathology due to thrush is an immunopathology. The fungus recruits very large amounts of neutrophils, and they cause inflammatory damage. There are two main agents of vaginal thrush, and interestingly enough, they are not the same in terms of this recruitment of neutrophils. So the most common form is Candida albicans, and secondary, but still large numbers, is Candida glabrata. Now, very interesting piece of basic research, which is now becoming a translational opportunity, comes from my colleague Duncan Wilson at Exeter, who found out what the signal was that was recruiting the neutrophils into the vaginal lumen. And it turns out to be a protein which scavenges zinc for the fungus. And if you give a lot of zinc, they don't make that protein, and the neutrophils don't come in. And this was discovered by basic research, but it actually matched some observations made that some lubricants, for example, which had high levels of zinc in them for various completely different reasons to make them more fluid-like, they had very good, there was reports that they were quite good at suppressing vaginal infections. So actually this is going out now as a clinical trial to really look whether that works. It doesn't work for glabrata. They don't use that zinc scavenging system at all. So you have to know which one is which. And again, very different for bacterial vaginitis. But, you know, there are some, the lesson to me is that actually understanding the disease can open up opportunities for treating the disease.
Thank you very much. And if I may, I've got a couple of questions for Ed as well. Ed, you mentioned fecal transplant, and you mentioned that someone receiving a fecal transplant still at risk of developing C. diff, they're treated with antibiotics. Where do that C. diff come from? Still the patients that they haven't managed to get rid of, or from the transplant itself?
Yes, thanks for the question. Not from the transplant itself. I mean that is so the donor screening program is very intensive. I mean, it costs about 800 to 900 euros to screen one donor completely for all microbiological agents that can be present and can cause disease. And one of the first agents, of course, is C. diff. So the donor is not the source. So we did a study in which we tested all the patients after FMT 1 year later. And I think it was about 15 to 20% still had C. diff. And we were not able in that time to compare the C. diff strains with the strains that originally caused the infections. So indeed, it's maybe the original strain that persists, or it may be an acquirement from the environment. So we don't know how this exactly works. However, it amazed me because I thought, okay, the microbiome is completely restored, and it should give a good protection against new colonizations of C. diff. So I assume that it's the strain that was originally present and has an equilibrium with its host. However, if you disrupt the microbiota again with an coamoxiclav or with a cephalosporin, in the patients that had just underwent a fetus microbiota transplantation, the chance is very high that the patient returned to his original states with his disrupted microbiome and his lack of immunity against toxin A and toxin B, and then suffers from an infection. And in fact, this is the most important failure of FMT. So we think in the hospital that's okay, we do an FMT and we applaud for ourselves because the patient has been cured, and then the patient is discharged from the hospital, is going to the general practitioner because he has a simple urinary tract infection, and the practitioner prescribes a cephalosporin, and immediately C. diff is back. So important is again that the care of those patients doesn't stop when the patient leave the hospital. It should be continued, and he should have an etiquette with, okay, please be very careful with the prescription of antibiotics because I had a fetus microbiota transplantation.
Okay, thank you. I've got a second question, very quick. I know in the break, so if I may. Both of you mentioned the importance in the environment as well, but especially you showed the map with One Health, with all your pigs, very nice picture of the pig, with C. diff. So what can be done? I mean, at the moment it's all about One Health, trying to control those microorganisms in different sources as well as humans. So on antibiotics treating, or any type of antibiotics treating your pigs or your animals, this is not going to work. So have you got any comments or ideas on that one?
Yes, I mean, it's extremely difficult to get to make recommendation because there's a whole industry behind the pigs, of course. It's not only pigs, but also humans behind the pigs. So it's difficult to give recommendations. They're doing very experimental studies now with probiotica, for instance, to see if you can just inhibit those strains in pigs. Not very successful until now, so I can't give you good recommendation how to do it. I can only recommend to do surveillance studies in the animals. I mean, we are also doing surveillance studies in calves and in horses, and we also see the C. diff strains that are nearly identical as in humans. So indeed, it's a One Health problem. It's humans, environment and animals. We cannot direct to which direction it goes. It may also be that humans has just infected the environment and subsequently pigs and just crossed the species barrier in pigs. So that's also possible. So I don't have an answer for your question.